you, Dr. Vittal. Thank you, Pravinda ma'am, for giving me this opportunity. Today I'm here with the topic periodontal therapy and glycemic control in type 2 diabetes. So we all are very well aware what diabetes is today. It is a public health concern worldwide, and the estimate by the World Health Organization says the number of people with type 2 diabetes reaching 366 million by the year 2030, and India being the capital for that. When you talk of periodontitis, it's also a major public health concern, contributing significantly to the global burden of oral diseases, and half of the Indian adults, they suffer from some form of the periodontal disease. Severe periodontal disease affects 10 to 15% of the adult population. When you talk of prevalence of periodontitis, males, they have a higher proportion of periodontitis as compared to females, and subjects aged 65 years and above, they have higher prevalence of periodontitis, whereas subjects aged below 35 years, they have higher proportion of gingivitis. So mainly periodontitis is a disease of 4th to 5th decade disease. It starts with from 4th decade onwards. In the urban-rural comparison, the urban population have higher burden of gingivitis, whereas periodontal disease was more common in the rural population. Now, what actually is periodontitis? Dr. Neel has already told us. So it's an inflammatory disease of the supporting tissues of the teeth caused by specific microorganisms or groups of specific microorganisms, resulting in the progressive destruction of the periodontal ligament, alveolar bone, with periodontal pocket formation, gingival recession, or both. So the damage to any supporting tissues of the tooth is periodontitis. Now, what is the relationship of periodontal disease and diabetes mellitus? It's a two-way relation. So, bidirectional relationship. Individuals with diabetes, they are about 2.5 times more likely to have periodontitis than medically healthy controls. And when severe periodontal disease often coexists with severe diabetes, and the disease tends to be most severe in patients with the poorest glycemic control. And as the infection and the advanced glycation end product mediated cytokine increases, the tissue destruction in diabetic periodontitis becomes faster, and this is how the periodontal infection may complicate the severity of diabetes and the degree of metabolic control. Now, what actually happens when we reduce the periodontal inflammation by reducing the periodontal infection? There is significant reduction in insulin requirement in the diabetic patients, thus significantly indicating short-term improvement in the concentration of glycated hemoglobin. So now, since there is very limited information available till date regarding the effect of the periodontal therapy on metabolic control, we came up with the objectives to evaluate the influence of non-surgical periodontal therapy on serum levels of HbA1c in patients with type 2 diabetes mellitus. We came up with the hypothesis that non-surgical periodontal treatment, it reduces HbA1c, improving the metabolic control in patients with type 2. The program of the work, we had around 150 type 2 diabetic patients suffering from generalized chronic periodontitis, selected from amongst the patients reporting at the diabetic units from the medicine department of AIMSA. The subjects for the study were selected in a non-randomized manner between the age group of 30 to 70 years. Their detailed medical and dental history is taken. The patients explained the purpose of the study and the procedures involved. The inclusion criteria for the participants or the subjects was, now patient, they had the confirmed diagnosis of diabetes for the last 6 months, and they were on regular follow-ups. Patients suffering from moderate to severe periodontitis, patients with at least presence of 15 natural teeth, patients not have received any periodontal treatment in the past 6 months, patients with 4 or more pockets of 4 millimeter or more, and probing attachment loss of 4 millimeter or more in at least 2 different quadrants, which bled on probing. Patients have not used any antibiotic in the past 3 months, and patients with the physical and mental ability to control their plaque to a clinical and acceptable level. In the exclusion criteria, Patients with type 1 diabetes were excluded. Patients suffering from diabetic complications like retinopathy, nephropathy, and neuropathy were excluded. Patients with a history of stroke in the last 12 months were excluded, and patients who had their medication changed during the course or in the previous 6 months were also not allowed for the study. Patients with any severe dental infection requiring drainage antibiotics were also not the part of this study. Pregnant females and patients currently receiving dialysis. Now, to assess the periodontal status, we had this CPITN probe given by WHO. The periodontal status was assessed using the following parameters, mainly the two indicators, gingival bleeding and periodontal pockets. Just the absence or presence of gingival bleeding with this probe, which had a 0.5 millimeter ball, and for the presence of periodontal pockets, we had the markings from 3.5 to 8.5, 3.5 to 5.5 millimeter, a black band, and then another band at 8.5 to 11.5. Now, this was the charting done, and it was very simple. If the bleeding was present, a score 1 was given. Bleeding absence means score 0. And for the pockets, if the pockets are from 4 to 5 millimeters, score 1 was given, and for pockets above 6 millimeters, score 2 was given. Now, the methods for the collection of data. On the first visit, the periodontal status of the patient was assessed using this CPI index given by WHO. And along with that, the blood sample also was taken for the subject to evaluate the serum glycated hemoglobin. And if the HbA1c was falling between 7 to 9 and the periodontal status was between moderate to severe, the patient was enrolled in the study with the informed consent. So, moderate periodontitis was classified when the pocket depth was between 4 to 5 millimeter, and when the pocket depth was 6 millimeter and above, it was severe periodontitis. So, after 12 weeks following scaling and root planing, or only scaling or no treatment, the subjects were recalled for recording the periodontal status using the same CPI modified index. Again, blood sample taken for the serum glycated hemoglobin. None of the final analyzed subjects had their medication changed during the course of study. So, these were the interventional procedures. In the treatment group A, we gave full mouth debridement consisting of oral hygiene instructions, subgingival scaling and root planing using ultrasonic device, and Gracie curates under local anesthesia, done in 2 visits at 1 week interval. And the group consisted of patients with pocket depth of 6 millimeter or more. In the treatment group B, we just gave oral hygiene instructions and supragingival removal of plaque and calculus with ultrasonic scaler. It is just a simple scaling process in dental terms. The group consisted of patients with pocket depth of 4 to 5 millimeters. In the treatment group C, which was a control group, there was no treatment delivered. The observations, we had HbA1c changes from baseline to 3 months visit, and changes in the clinical measurements of chronic periodontitis, whether bleeding it reduced or not, the mean periodontal pocket score, and the clinical attachment loss. The recording and analysis was done, and permission from the research and the ethical committee was taken prior to the study. So, in the total subject size of 150, 116 were males and 34 or 22.7% were females. Now, the duration for which subjects were diabetic, around 24% of the subjects, they were having diabetes from 5 to 10 years, and 31.3% were for more than 10 years. Now, this charting shows us the bleeding status, the mean periodontal pocket score, and attachment loss before the treatment was delivered. Around 492 sites bled out of 600 sites. The mean periodontal pocket score was 4.82 and 7.96 was the mean attachment loss score. The mean HbA1c score before treatment was delivered. In group A, it was 8.15 plus minus 1.43 standard deviation, In group B, it was 8.01. That was the only scaling group. Group C group was the control group. It is 8.11. And when group A and B was combined, it was 8.08. Now, this is the charting where the bleeding status, the mean periodontal pocket score, and attachment loss score was recorded after the treatment was delivered, whether it was scaling and root planing or only scaling. Now we are left with just 98 bleeding sites out of 492. There was a reduction of around 65% in the bleeding sites in the treatment groups. The mean periodontal pocket score dropped from 7.2 to 3.2, and the attachment loss score from 7.96 to 3.05. The mean HbA1c value. So these are of much importance to the physicians here. The mean HbA1c values, they dropped from 8.15 to 7.02 in group A. In group B, the reduction was from 8.01 to 7.60, and in group C, the control group, almost 8.08 to 8.04. So when we make a comparison of the treatment modalities on HbA1c, the group A had almost a percentage reduction of 13.9%. Group B, almost 5.1%. It was just the scaling group. When both the groups were combined, A and B, the percentage reduction was 9.5%, and in control group, it was almost negligible, 0.8%. So comparison of the mean HbA1c value among the scaling and root planning group and only scaling group. Group A and B comparison, it was found to be statistically significant. And comparison again of HbA1c value among the study groups before and after treatment, that is with the control group, again was found to be statistically significant with the p-value of 0.031. So this charting shows us most of the sites for bleeding were statistically significant, and periodontal mean score, only one site was statistically significant, and for attachment loss score, again, other than one, almost all sites were statistically significant. Now the discussion part. Now the observations that the periodontal therapy appears to reduce the periodontal infection and inflammation, it suggests that periodontal therapy may facilitate the metabolic control of diabetes, improving insulin sensitivity by reducing peripheral inflammatory cytokine levels. But the exact mechanism by which this happens have still not been fully elucidated. But the popular hypothesis involving the inflammatory pathways common to the pathogenesis of periodontitis and insulin resistance. Now, Grossi and Janko, along with Amar and Hen in 2003, they suggested the upregulation of pro-inflammatory cytokines, the tumor necrosis factor alpha, IL-1, IL-6 in periodontal disease may be responsible for insulin resistance and the poor glycemic control. Another study by Coro Mantos et al. In 2011, again all the parameters measured, bleeding, the gingival index, the periodontal pocket depth and attachment loss, they all improved after 3 months of non-surgical periodontal therapy. In another study by Singh et al. In 2008, HbA1c and all the other periodontal parameters, they showed improvement after 3 months. And also the percentage of sites with probing depth of 4 to 6 millimeter and greater than 7 millimeter, they reduced significantly in scaling and root planning group. Now, a study by Rodriguez in 2003, where group 2, where one stage full mouth scaling and root planing was done, they showed a reduction of HbA1c levels of up to 11%, and it was statistically significant. Another study by Panseria in 2012 also showed a reduction of 12% after 3 months of non-surgical periodontal therapy. The results were similar to our study, where we had around 9.5% when both the groups were combined and 13.9% in group A, where deep scaling and curettage was done. Another study by Coromentos in 2017 evaluated the reduction in glycated hemoglobin at 3 to 4 months after periodontal treatment. It showed a reduction in HbA1c ranging from 0.27 to 1.03. Now, this meta-analysis indicated that effective non-surgical periodontal treatment in people with diabetes, they result in statistically significant reduction in glycated hemoglobin levels at 3 months. Now, these studies, they did not show any significant additional impact of the antibiotics use on glycemic control. Another study done in New York University, United States, the mean reduction in HbA1c noted was around 7.8%, which was almost similar to our study of where we showed a reduction of 9.5%. The reduction in HbA1c in treatment group A was 1.13, and in group B it was 0.41, whereas HbA1c decreased by 10.8% in a study done by Kaur et al. In 2015. Another systemic review on RCT by Chen et al. In 2021, he concluded that the significant benefit of periodontal treatment on glycemic control in patients with type 2 diabetes and periodontitis. So the clinical benefit was mainly found with high baseline glycosited hemoglobin level. Now, it has been reported that the inflammation directly induces insulin resistance in type 2 diabetes patient. There has been significant decrease of plasma levels of several inflammation markers like interleukin, IL-1 beta and IL-6 compared with the baseline levels after periodontal therapy. The periodontal treatment in type 2 diabetic patients is effective in improving the metabolic control, possibly through reduced tumor necrosis factor alpha levels and thus improving the insulin resistance. Now, this is more important. The clinical implications of achieving better metabolic control of diabetic patients, they are clearly established. Specifically, the microvascular complications related to diabetes, they are reduced by 35% for each 1% decrease in HbA1c level. Additionally, an absolute decrease in 1% in HbA1c level can decrease the risk of any death related to diabetes by 21%, as shown by Selvin in 2010. Now, to conclude that the non-surgical periodontal therapy, it was clinically effective and had a statistically significant effect on the participants' glycemic control. The implications for clinical practice. Now, the clinician has to be very well aware of the two-way street of the disease cycle. The results in greater periodontal disease in those with diabetes and poorer glycemic control. The healthcare provider should inform the patients of diabetes of this link and engage in oral health education programs. Oral healthcare provider should perform a periodontal examination in each newly diagnosed diabetic patient, and physicians should seek the evidence for the presence of periodontitis in patients with diabetes and ask about the signs and symptoms of bleeding gums, drifting dentition, halitosis, and gum soreness. Thank you.